and we'll proceed. Good afternoon, everyone. Welcome to our webinar. We will begin with welcoming remarks by the President of the Touro College and University System, Dr. Alan Kadish. Dr. Kadish, we look forward to your remarks.
Thank you, Dr. Halpern. It seems hard to believe that only 2 months ago, the Center for Disaster Medicine of New York Medical College and Touro presented our initial coronavirus educational seminar, What We Know, What We Don't Know, and What We Need to Know. That day, we assembled experts to share vital information with the public because as physicians, scientists, and educators, we understood the devastating potential of a pandemic and hoped to spare as many people as possible from contracting COVID-19. Our live event took place on Friday, January 31st at our Midtown campus, which was attended by the public and members of the press. Following the 4-hour event, we all were happy to go home and begin our weekend with family and friends. What a difference 2 months has made. Who could envision at that time what life would be like under quarantine? Being confined to our homes has changed the way most people feel about many things. In some cases, it's been difficult to adjust, and most of us are anxious to control the pandemic and get back to our work and to our rich lives. Several months ago, the virus was centered in Wuhan, China, and only a few cases were found in the United States. Today, as we speak, the United States has the largest number of cases in the world, with more than 145,000 cases. And New York, where we are broadcasting from, has many of those cases with 60,000 infected and sadly, over 1,000 deaths. Worldwide, as of this morning, 745,000 people had been documented to have coronavirus, and the true number is quite a bit larger. And worldwide, there have been 35,000 deaths. As my friend and colleague, Dr. Halpern, pointed out at our first summit, pandemics tend to bring out the worst in people and the best in some others. The worst includes some things we've seen, but our goal is to try to foster the best. And I'm proud to say that members of the Touro College and University System have tried to help do what we can to deal with the pandemic. In addition to organizing our January conference and its next installment today, we have transitioned 16,000 students to online education with no interruption in classes. New York Medical College students and Touro medical students, pharmacy students, dental students, law students, and mental health counseling students have stepped up to volunteer in Orange County, in Westchester, in Manhattan, in Brooklyn, in Las Vegas, and in California. They're working with patients, with the disadvantaged, and with the homeless to help deal with the medical devastation and the stress of the current COVID infection. New York Medical College is participating in trials of medications to treat coronavirus. Touro faculty are spearheading better access to testing, and we're working with regulators to speed the entry of healthcare workers into the fight to contain COVID-19. People have compared what we're going through to the flu pandemic of 1918. The most glaring difference is that science and medicine have vastly improved since then. I have great confidence that in the weeks and months to come, in addition to the frightening news of rising cases, we will be encouraged by testing, treatment, and vaccine breakthroughs. That has been the history of science and healthcare. Many of us have been racing for a cure, and God willing, the pandemic will be behind us sooner than previous generations had to wait. In the meantime, we must be patient and do the right thing. Educate ourselves. For those of us who are not essential workers, stay at home, practice social distancing, and deal with the recommendations that you'll hear about today. Today, I'm delighted to introduce some of the leading experts in infectious disease, healthcare, and education, as we discuss important aspects of this pandemic and how we can respond, limit the damage, and prevent future infections. Thank you.
Thank you, Dr. Kadish. We will begin our presentations with the presentation of Dr. Robert Amler, Dean of the School of Health Science and Practice at New York Medical College and a former officer of the Center for Disease Control. Dr. Robert Amler, please.
Good afternoon, everyone, and greetings from the New York Medical College campus in Westchester. I'm Dr. Robert Amler, and I was co-founder of our Center for Disaster Medicine, which is part of the sponsorship of this webinar. I'll discuss briefly, but first I'll say I have no conflicts to disclose, and I'll share these slides with you momentarily. Please stand by. And there we are. The Center for Disaster Medicine at New York Medical College is engaged in education and research, but also training and drilling for the kinds of different types of disasters that can befall communities: biological, chemical, explosive, active shooter, and today we're talking principally biological, but in the center we always teach principles instead of preaching protocols, because the response in communities and the consequence management after a catastrophe has struck follows similar patterns, whether regardless of the type of injury that occurs, just like heart muscle, liver, lung respond and recover to injury in similar patterns, regardless of the cause. But today we're talking about coronavirus, and the basic characteristics are that it is an emerging infection. We all know. We know about the person-to-person transmission, and that transmission turns out to be quite rapid. It also can cause a mild disease, but also severe and lethal disease. We're dealing, as we were 2 months ago, still with an evolving situation here and worldwide, with guidelines changing over time. So everything said today is being said with an air of caution, because things can and will continue to change as we experience and learn more about this terrible virus. Well, how does it move through populations? We'll all remember in December 2019, we were told the first human case or cases occurred in China, and there was human-to-human transmission documented as early as January, and there was travel-related transmission also noted in January. Later, we became aware that even after travel-associated imported cases, we saw transmission within communities that caused a greater and wider problem that persists today. We know that it started here in China, and this slide from January shows the emergence of the virus in the central part of China, Wuhan, city of 11 million people, and a very busy industrial and cultural and population complex, where already there were some 3,000 plus dead, even at the end of January. And we saw that with travel, within just a few days, other countries, as of February 2nd, 28 locations around the world were already reporting cases. Well, and now here we are with the pandemic. You can see from the comparison of the maps, the very wide geographic spread to almost every country in the world. And we could imagine that even the countries not showing as having cases may well have cases that are as yet unreported. This is how the pandemic has taken shape from an epidemiologic perspective. You can see the initial cases. The timeline is on the bottom axis, starting all the way on the left from the end of December and going right up to the end of last week and this weekend. You can see right through the end of January and February, almost all of the cases which are in green were in China. And then you see gradually small numbers of additional bars, additional colors adding to the height of the bars. As the number of cases decreased in China, we saw increases in other parts of the world. The Americas, by the way, shown in yellow, the European countries shown in a pink or salmon color. And you can see, interestingly, that although the United States currently is reporting the largest number of cases of any single country, that in fact, taking European, all 40 or 45 European countries as a whole, that Europe has many more cases, more than twice as many cases as the United States. In the United States, you can see the epidemiologic curve and how it has played out. You can see that as early as the earliest part of March, we had barely any cases in the US from those very, very low blue bars on the left. And you can see how they rise with a greater and greater slope right up to the present time, where at this point, and these are early weekend numbers, 120,000, but as Dr. Kadish said, it's now more than 145,000 reported COVID-19 cases in the United States. What we are seeing is roughly 20,000 new cases reported every day. And here in New York State, 52,000 last Friday, now over 60,000 cases, and in New York State alone, over 700 deaths have occurred. Well, let's look again at the transmission situation. We've said from the beginning that this is a virus that spreads by the respiratory route, by droplets spread from person to person. We have now begun to investigate cases of spread from surfaces that can be touched, where we know that viruses can remain recoverable after quite some time, even 2 or 3 days. And we're not sure, but we suspect that there could be also some airborne spread in which droplets remain suspended in the air for some time. We are estimated an incubation period, presumed 2 to 14 days. Don't really know the upper limits on those. The World Health Organization declared a pandemic only 2 weeks ago, and the real question on everybody's mind is how far will this go? Well, we have some ability to model this with caution because we really don't know our numbers yet. But if we look at a metric called R sub 0, or what we call R naught, when we compare other infections like Ebola and influenza, they will typically infect 1 to 2 to 3 people per infected case. And if you extrapolate this out to your number of cases, you can try to predict in a mathematical way how many cases you will generate over what period of time times the incubation period, how many cycles times the incubation period. For pertussis and for measles, the R naught values are much higher. It's been estimated several weeks ago from a study in China that among their cases, the R naught value was 2.28, which puts COVID-19 somewhere in the middle of infectivity. But as I've said to our students, remember, R naught values are not the ultimate answer, because the R naught value is calculated from a fairly simplistic model like you see here. Index case, in this case called E, spreads the disease to a number of other people who in turn spread it to a number of other people, and you can count the generations of cases from the very first index case to secondary cases, tertiary cases, and the like. And we call this the WAIF matrix, where WAIFW is a not very sophisticated acronym for who acquires infection from whom. Well, that would all be great in an ideal or low transmission setting. But in most cases like this, we're looking at transmission that is more like this. You can see lots of people infected, giving the infection to variable numbers of people depending on circumstances, and many times for any given case that is reported, you could speculate many different people from whom they caught the infection. And that makes that whole modeling of R naught, as I said, not the easiest metric to measure and not the best predictor of what will happen next. In fact, sadly, there is no guidebook currently that has a chapter called COVID-19 that would give you the information on this slide. These are the metrics that we need to know in order to understand this virus and how best to defeat it in human populations. I won't read every item here, but you can see we need to know its natural course, the incubation period, the case fatality rate, the age considerations, measures of protective immunity. Just finding an antibody doesn't always mean it's protective. How do we know that's protective antibody? And finally, the reinfection potential and vaccine potential and efficacy. These are all vital stats that we need to learn over the next several weeks and months. But that's where the real benefits are of the latest intervention, which is more widespread testing. Certainly when you test widely, as we are now doing in this country, we'll identify a more complete panel of patients and be able to refer them for appropriate management. But we will also make some headway in filling out the details on that blank page in the guidebook or textbook, because we will finally be able to characterize the dynamics of COVID-19 and understand better what we're dealing with and what our public needs to understand to help contain the infection. So we are still left with this question: how far will this go? Every call that I get, every call that our health departments get, centers around this essential question: how far will this go? What is the infectivity, the invasiveness, the incubation period, contact rates, and how resistant will our population be? Finally, we are now introducing some pharmaceutical tactics that will hopefully mitigate further and reduce the height of that curve, basically flatten the curve, as you've heard task force members say in Washington almost every day. So, in summary, the situation's still evolving. We know this is, for some people, a serious and fatal infection. And if you're within shot of my voice right now, please take care. Take this infection very seriously. Even though the majority of people are not badly affected, you don't know who you could pass this on to, and they could be somebody who suffers badly. So please, everyone, lean forward, because the best defense right now is a good offense. We will lean forward and take every possible step to contain this virus. And for all of us on this webinar, let's keep the public, our patients, and medical colleagues informed as new developments emerge. Thank you.
Thank you, Dr. Robert Amler. We will now have our next speaker, Dr. Marissa Montecalvo, Professor of Infectious Disease at New York Medical College and the Westchester Medical Center, who will talk to us about clinical management. Dr. Montecalvo, we look forward to your remarks.
Good afternoon. I'll be speaking about the clinical management of suspected and confirmed cases. I have no conflicts of interest to disclose. In speaking about the clinical management of suspected and confirmed cases, I will talk a bit about transmission and testing, the clinical presentations, outcomes, and treatments. I'd like to start, next slide please, with early transmission dynamics. So as Dr. Amler spoke about, we are looking at an incubation period that was assumed to be 2 to 14 days based upon the prior SARS experience. But in the article by Lee, where they interviewed patients who had clear exposure to the Hunan seafood market where this began in Wuhan, China, they were able to look very carefully at the exposures that patients had very early in this epidemic before there was widespread community transmission. And based upon that work, the median incubation period appears to be 5.2 days, with the range, as you can see, all the way out to 14 days. And as has already been said, with a transmissibility factor of greater than 2. This work on incubation period was recently replicated by Lauer, who also looked very carefully at identifiable exposures. And so it looks as though the mean incubation period is around 5 to 6 days. Next slide, please. When we look at the detection of virus, if you look at the graph here, this has cycle thresholds on PCR, and the lower the cycle threshold on the y-axis, the higher the viral load. It means that the polymerase chain reaction is showing positivity sooner at fewer thresholds. And what is seen here in the analysis of these 17 patients is that the lowest cycle thresholds are early on after the onset of symptoms, similar to the transmission that we see with influenza, and not like SARS, where transmissibility was later on in infection. The other thing that this study showed was that the nasopharyngeal swab had a better yield than oropharyngeal swabs. Hit enter, please. And so on March 12th, CDC recommended that only a nasopharyngeal swab would be needed for diagnoses. Next slide. When we look at the characteristics and important lessons from the CDC in China, they looked at the first 44,000 cases, and of which the majority were aged 30 to 79, and the majority had mild disease. The case fatality across these cases was 2.3%, again, much higher if one had comorbid conditions, such as diabetes, lung disease, or coronary artery disease, higher in the elderly, and if one becomes critically ill from this disease, the mortality is extraordinarily high. The other thing that was seen in this study, and I think is very important for us in the United States now, it was that 4% were healthcare workers, and transmission to healthcare workers clearly can occur and did occur. Next slide. If we look at the clinical presentation, and there have been several studies reviewing this, but they all show about the same thing, which is that the most common symptoms are fever and cough, myalgias in about half the people, sputum production in about a third, diarrhea may or may not be present, lymphopenia is the most common laboratory finding. In this graph, what you see is progression as the timeline from symptom onset to either shortness of breath, acute respiratory distress syndrome, or ICU admission. And I think what is very striking in this is that if someone develops shortness of breath, the timeline from shortness of breath to ICU admission is actually quite short. It's 2 days. And this has been shown in other studies as well. The ICU patients usually have even greater lymphopenia, a high LDH, and they appear to be having a cytokine storm with very high helper cells as well as suppressor cells being activated. So I think what has been seen in several studies at this point is that when one gets to the point of shortness of breath and an early acute respiratory distress syndrome, the progression can be quite rapid. Next slide, please. This is a radiographic presentation of COVID, and here you see a mild left basilar infiltrate, quite subtle, that was seen on day 9 of illness, but it can be the presentation can be much more dramatic and severe. In the next slide, you will see the first radiograph is one of the first 3 patients described in the literature. This patient died of this multifocal pneumonia due to COVID-19. And the other 2 x-rays show you a subtle infiltrate in the left upper lobe that quickly progresses by day 8. Next slide, please. If one looks at abnormalities on CAT scan, this is a study looking at approximately 1,100 patients from China. Abnormalities are very common. A ground glass opacity is one of the early findings and one of the more common findings, along with patchy shadowing, and then going on to bilateral infiltrates and interstitial abnormalities. Next slide, please. So when it comes to outcome, of course, a lot of this is still to be determined. It's hard to know what a death rate is when you're not really sure of the number of people who are truly infected. But there are some studies that I think are important to point out. Looking at patients who were pregnant, this was from China, it's only 9 patients, but they were able to look for intrauterine transmission by polymerase chain reaction and did not find any evidence of intrauterine transmission. All 9 patients delivered and did well. In children, children appear to do fairly well with this infection. So an early study of just 6 children was reported, and they did very well. A larger study just came out looking at 171 children, of which 65% had pneumonia and only 3 required ICU admission. This is similar to the experience with SARS, where in general, there were few infections in children and children did well. When it comes to death rates, I think what is clearest is that if one progresses to acute respiratory distress syndrome, the death rate is severe, with death rates of up to 50% being reported. Next slide, please. So this is a colorful slide that I want to take a moment to go through with you because I think it gives some very important information. This was an early study where they looked at 18 patients, 12 of whom had uncomplicated disease, 6 of whom required oxygen, and they looked at viral loads. So the green is, you're looking at, every line here is an individual patient, and the green is, dark green is symptomatic, febrile illness, light green is afebrile illness. But what I want you to focus on is the blue section. The blue is when the patient is asymptomatic at the end of their illness. And the red and green dots in the blue section indicate when virus could still be detected by PCR. So you can see as you look across the blue sections that there are several red dots. And up to 2 weeks after improvement, one can still detect virus by PCR. Now, it may not be live virus, but the PCR is still positive. And that is an important point for us in that, hit enter please, in that we do not want to test asymptomatic patients. Next slide. I was asked to comment on the management of suspect cases. So although testing is now widely available, we are often in the situation of having suspect cases. Both confirmed and suspect cases require isolation. At this point, given the widespread community transmission, if someone is a close contact and has consistent symptoms, one would certainly assume that that person has COVID-19 and treat them the same as a confirmed case. And I just want to mention, as in any epidemic, it's always important to remember all the other causes of respiratory illness, that not everyone will have this, although clearly many, many, many people will. But I think the key points about suspect case management is that you treat the patient essentially as if they were a confirmed case. Next slide, please. So in this slide, I'm going to use this slide to lead into treatment. Before we can talk about treatment, we have to talk about the biology of this virus. And so what you're looking at right now shows a human cell, a lung cell, with its receptors, the ACE receptors, where the virus spike proteins bind to. And ACE receptors happen to be increased in general in persons with diabetes and those treated with ACE inhibitors. Hit enter, please. So here we're going to go through the infection with the virus. So you see the virus in the upper left-hand corner. There are 4 important proteins in this RNA virus: the S protein or spike protein, the N, E, and M proteins. What happens is this spike protein fuses with the ACE receptor and there uncoats and enters the cell. You then have RNA replication. You then have the building of new virus through polyprotein processing, and you then have exiting of the virus out of the cell. Each of these steps gives us an opportunity for potential intervention. So some of the, hit enter please. So one of the drugs that you've heard about is chloroquine, an anti-malarial and a drug that can be used in inflammatory conditions. So chloroquine can interfere with fusion, a very important step. Hit enter, please. Remdesivir is an antiviral from which there is experience in treatment of Mideastern coronavirus and will interfere with viral replication. And lastly, hit enter, please, the HIV protease inhibitors can interfere with the polyprotein processing. Next slide. So when we look at treatment, here's where we're at. Hydroxychloroquine, which is another formulation of chloroquine in which we get higher levels in serum as well as in the lungs, increases endosomal pH and can interfere with cell fusion. It also interferes with the viral proteins, and it's an immune modulator. So it has multiple mechanisms by which it may interfere with viral replication. There's an open label trial going on with the use. There was an open label trial published on the use of hydroxychloroquine, which did show a significant reduction in viral detection from nasopharyngeal swabs 6 days into treatment. Some of those patients also received azithromycin, and they seemed to do best. But I want to caution everyone, this is a small study, 20 patients with controls from a different center, and we really need good randomized data to know whether this is effective treatment. Remdesivir is a broad-spectrum antiviral that was used with Mideastern coronavirus and will inhibit COVID-19. And lastly, the HIV protease inhibitors, lopinavir and ritonavir, which there was also experience with MERS infection. There was just a paper published looking at the use of lopinavir, ritonavir versus standard care, and there was no difference in time to clinical improvement, but patients were not treated until day 13, which may have been too late to start treatment. Next slide, please. And lastly, the other area for treatment is to deal with the cytokine storm. And for those patients who develop shortness of breath, looking at blocking cytokines like an IL-6 receptor blocking antibody is also an avenue for treatment. Next slide, please. So yesterday, looking at clinicaltrials.org, there were 202 trials for the treatment of COVID-19 listed, with 88 already recruiting patients. There's a lot of work going on with the use of hydroxychloroquine, both as preemptive treatment and even as post-exposure prophylaxis. There are trials looking at it for severe disease in combination and against protease inhibitors. Remdesivir is available for compassionate use, and there are open label studies going on, as well as a phase 3 placebo-controlled study. IL-6 receptor blockers are also being studied, of which there are 3 that are already available for other diseases. And lastly, the use of convalescent neutralizing antibodies from patients who have had COVID infection. There are many, many other studies: high-dose vitamin C, nitrous oxide to reduce mechanical ventilation, and importantly, studies looking at the cardiovascular events that patients experience who are infected with COVID-19, and also natural history studies looking at these patients who also have hypertension and the effect of use of ACE inhibitors in these patients. And lastly, the vaccine study has opened with an open label phase 1 study looking at the immunogenicity of 3 doses of a messenger RNA vaccine that will encode for the pre-fusion S protein. I want to conclude with this unbelievable picture from Science magazine looking at the spike protein of coronavirus approaching the receptor in the lung. And so what do we know so far? Well, I think the clinical course has been pretty well described. There are many, many studies out there. We will learn more about transmission and testing, but clearly the area where we really need so much assistance is in clinical trials and to better understand the biology of the infection and immunity and prevention. Thank you very much.
Thank you, Dr. Montecalvo. We have gone from about 600 people joining the webinar when we began at 2:30 to over 720. Ashley, please put these slides up for continuing medical education credit, please. For those of you who did not see the first set of information on continuing medical education credit, the slides will appear shortly regarding CME credit. You may obtain CME credit by registering. You can, for example, text to the phone number 828-295, again, continue the code 3 on continuing medical education credit, and then OLA, or you can go to the www.weds.com and click sign in. For those of you who are watching this broadcast as it was recorded and are watching several days from now, you will note that the activity code expires on Friday afternoon. So you can only enter your name if you accomplish the task before Friday at 2:30. Once again, for those wanting CME credit, you must sign in for attendance, and you will have to fill out the online questionnaire about today's webinar. So you can text the code 33BOLA to 828-295-1144 or go to www.eeds.com and sign up for your CME credit. This program is approved for 1.5 American Medical Association PRA Category 1 credits. Thank you, Ashley. We will now hear from Professor Jeffrey Lichtman of the Touro College Graduate School of Education, who's going to give you some practical mental health advice while sheltering in place as to how to deal with the fact that the kids are driving you crazy and staying in this house is driving me crazy. Professor Lichtman, we look forward to your
Okay, thank you. Thank you, Dr. Halperin. Good afternoon. I have no conflict of interest to disclose at this time. So yes, you're going crazy and your children are driving you crazy. Hopefully that's not the case, but let's talk about the anxiety that I think it's fair to say that everybody is experiencing and some tips for what you can do about it. You know, it's important to remember that each of us, every human being is unique. Beyond the uniqueness that is each one of us and our unique situations, we're also all the same. So in other words, it is very normal to be concerned with what is taking up the world's attention, all of our attention. More to the point, I think it's very normal to experience levels of anxiety around the unknown. And if you've been paying attention to this presentation up until this point, the one thing that is clear is that while we've learned some things, there is so much that is unknown. And we as human beings don't like what's unknown. We don't like what's unfamiliar. And so that causes us anxiety. And it's normal also to experience some anxiety around significant changes in routine. And that's probably the other thing that we're all sharing in common. There's hardly any of us, I would suggest, who don't have some significant change in routine. The unknown, the changes in routine, all of these take away our feelings of control. And you know, one could suggest that part of the goal in life is to exercise control. And this pandemic is creating anxiety due to the fact that we have these feelings of limited control. So what can we do about that? The first thing is to understand that you know, that this anxiety is normal, to understand what we're feeling, to understand why we're feeling it. That's the starting point for managing our feelings. And again, it's about managing our feelings. There's no, we're not looking to dismiss all anxiety. That would be inhuman. And anxiety serves a function as well. It's anxiety that gets us to study for exams that we need to study and prepare for. And it's anxiety that is driving us to practice the social distancing that we must in the current climate. So it becomes a question of degree. And from that perspective, for instance, we are all besieged, I think, by ongoing 24-hour news around the virus. You can watch it on TV, you can listen to the radio, you can stream it on your computer. And if you hear me say little else, I want to suggest to you that if you're one of those people who's doing that, please stop doing that. It is not healthy from a psychological perspective for you to be tuned in and to be listening for every, you know, moment to moment to every update on the news. There are few updates of consequence. It is, again, natural and normal to want to know if there are any updates. So in the morning, tune in, listen to the news. In the evening, not before you go to sleep, but sometime earlier in the evening, listen to the news once or twice a day. More than that is really not healthy and not beneficial, and only will potentially lead to increased anxiety. And what we're talking about is trying to decrease anxiety. The other thing I want to suggest to you is that, you know, anxiety relates to what we're focused on. You can't not focus on this pandemic that is surrounding us, but you can refocus and should refocus to other things. We can be refocusing to the work that we do, even if we're working remotely or in other sorts of ways. This is an opportunity perhaps to work on aspects of the work that we sometimes don't get as much time to work on as we can. Perhaps more important than anything I can say to you is what a great opportunity if we're fortunate to have family and friends. This is a great opportunity, particularly for family, to focus on family, to take advantage of time that we have with family. And by the way, even if they're not with us, but reaching out in other ways. So think about your work in interesting ways. Certainly focus on your family, and even think about that book that you've been wanting to read for a long time. And now perhaps is the time. So it's about balance. It's about living in the moment. If you will, if you're thinking about all the terrible things that can be happening from this pandemic, terrible things can happen. That is true. Most of us, however, overwhelmingly, as you've heard earlier in this presentation, are not at risk for serious illness. That doesn't mean that we don't have to take good precautions. None of us know who's at risk, but overwhelmingly, most of us are not. And you can be thinking about that fact as well. And you can be thinking about, so you balance, if you will. If you're going to think about all the negative things, think about all of the positive things as you will. Which leads me to another point, which is that if you're dealing with this crisis, how do you deal with the crisis? Well, you need to break it down into its component parts, into manageable parts. So think about a plan. Whatever that plan is, whether it's a plan for your work, which has changed dramatically, maybe more to the point, in the title of this presentation, my kids are driving me crazy. So many of us have children or grandchildren at home with us because school is out. What a great opportunity not to be driven crazy, but to structure and to make a plan for how we're going to work with those children. How they need structure. Children need structure. We can provide them with that structure. So let's make a plan for how we're going to work with our children, how we're going to manage other aspects of the crisis. When you make a plan, it becomes more manageable for us. And as a result of that, our anxiety tends to reduce in part. I think it's important to note at this point that if you're making a plan, share the plan with your significant others. We're not mind readers. Even psychologists can't read your mind. And if you've got a plan, share it with your spouse or significant others. Share it with your children. Ask for their input. Other people have great perspectives sometimes. And that's a great way also of reducing anxiety. As we have a plan that we can work on, as we have something that we can do, it helps us to limit and minimize anxiety. And for children in particular, it's important to be talking with them about this and to a reasonable degree. That means not all the time. And that also means not in one setting. You're not going to sit down with your children and explain to them in a few minutes everything they need to know about the pandemic. And even if you could, that's not what they need. What they need is over a period of time, and we're in this for some period of time, from time to time, to raise the issue with them, to ask them if they have any concerns, to reassure them, to share reasonably some of the concerns that you have. It's again the unknown that is the most frightening thing. And if you don't answer children's questions, if you don't give them information, then their minds, as our minds, are capable of going to places that are very scary, and we don't want that to happen. Keep in mind, again, as a last point around children, that children are of different ages. If you're talking about younger children, preschool age children, early elementary school age children, there's very little abstract thinking there. It's all concrete thinking. And so therefore your sharing, your remarks need to be very much rooted in the concrete. Obviously, as children get older, you can share with them on a more abstract level, which leads me to my next point, which is about communication. I said communicate the plan. More than that, it's important to talk about this. It's amazing and it's really wonderful that Turo is providing this webinar, this information, et cetera, but it also serves an additional function, not just for information, but it's the launching pad for discussion and for talking. When we talk about something, when we, if you will, name the monster is coronavirus. Once we name it, once we start to explain it, once we talk about it, all of those things help us to, again, lessen the anxiety that we're feeling around this very significant and troubling virus. I want to mention two things very quickly. Sleep. Sleep is always important, but at a time like this, when we are being assaulted, both emotionally and potentially physiologically, it's really important to get enough sleep. You know this, but I'm going to emphasize it. There should be no devices when we go to sleep. It's a relaxing bath or a book. And if you're really having difficulty going to sleep, then maybe a little bit of melatonin, to help you, which is natural and over the counter. So sleep is really important. It's also important, very important, to get exercise, whether you're walking or running. This challenge does not prevent us from getting exercise, and we should be getting exercise. Last but not least, the point that I want to share with you is that in every challenge, there are opportunities. We have a need for many things, including meaning in our life. And to the degree that we can reach out to those around us, those that we love, and those who are not yet loved by us, those who are neighbors, those who are frail or elderly, and to the degree that we include our children, if we have children with us, in reaching out through a phone call, through a FaceTime, through a Zoom, whatever it might be, helping out with grocery shopping or whatever it might be. All of those things can go a long way to not just helping those around us, which is so important, but to helping ourselves. Making someone else's life better floods our life with meaning. And that has huge health benefits beyond even the psychological benefits. So let me just conclude by sharing that I think everybody knows we're coming into a time period where we're celebrating holidays, Easter, Passover, Ramadan, and some of us are sad that we're not going to be together, perhaps with some of our loved ones. Nevertheless, we need to think about other things. These holidays are important to us. Passover is the ultimate holiday of hope, hope for the future, hope in going from slavery to freedom, from whatever enslaves us physically or emotionally, from slavery to peoplehood in the service of humanity, in the service of others. So with that in mind, may we all celebrate our own holidays in hope for a healthy, a more serene, and more giving future. Thank you.
Thank you, Professor Lichtman. We will now hear from the Public Health Commissioner of Westchester County, who is in the heart of the pandemic, perhaps was at the leading edge of it from some of the initial cases that were experienced in Westchester. We look forward now to hearing from Dr. Sherlita Amler, who has taken time from her very, very busy schedule to chat with us this afternoon. Dr. Amler.
Hi, Dr. Kadish. Thank you so much for allowing me to present today. And I'll be getting my slides up. I do want to say that I have nothing to disclose. And so we'll get started here. So I think the most important message that people need to hear is that without exposure, we have no risk. And without risk, there is no infection. And no infection means no illness. So if you are home isolating yourself and you're not exposed to others, you have absolutely no risk of getting this disease. Now, that being said, it's a lot easier to say it than it is to actually do it. But certainly for older individuals and individuals with immunological compromising conditions, I think that does give them some measure of security. So let's talk about personal measures. What can we do if we have to go out into the world that can make us safe? These non-pharmacological measures can really make a distance. And I think one of the most important is social distancing. We would like people to stay 6 feet away from each other when all possible. That means, if you get into an elevator, you don't want there to be 10 people in that elevator with you. If the elevator is crowded, wait, take your time, get on an elevator that's not crowded. Hand washing and hand sanitizers. We'll talk more about that in just a minute. But very, very important to keep us all safe. We need to keep our hands off our face. We actually touch our face a couple hundred times a day. Some people more than others. but certainly we touch our face a lot. And when we do that, rubbing our eyes or putting our fingers in our mouth, we actually have the ability to inoculate ourselves with this virus. And so it's very important to be conscious of keeping your hands away from your eyes and out of your mouth. You want to avoid people who are coughing or sneezing. And when you do cough or sneeze, be considerate of others. Use a Kleenex, use your elbow. And if you're using a Kleenex, don't leave it for someone else to pick up. Please put it in the trash can and try not to contaminate surfaces. If possible, we would like people to stay home. Social distancing by staying at home is a great way to prevent people from getting sick, but this is especially true if you are already sick. We don't want you going out spreading your illness to those people that you love and care about or people you work with. So anyone who suspects they might have coronavirus, COVID-19, needs to be at home. We want you to self-quarantine when you've been exposed. So if you've been exposed to a positive case or someone who is highly suspected of being a case, very important that you quarantine yourself away from others. So this is what a sneeze looks like. This is an historic photograph, and many people have already seen this, but it bears looking at again because you can see the volume and just the force with which a person sneezes and all these particles going out into the air, into surfaces, landing on surfaces, contaminating these surfaces. Very, very important that we try to limit this. And so this is where face masks can come into use. Certainly, surgical masks do not protect you from those around you, but if you are actively coughing or sneezing and you put a surgical mask on, you could prevent all of this material leaving the individual who's coughing or sneezing from being projected into the air and landing on other people or surfaces. So let's talk about hands. As I said before, very important not to touch your face. Not a time to be shaking hands. It's a very hard habit to break. I find myself having difficulty with this, but still, whenever possible, don't shake people's hands. Don't touch handrails or handles, elevator buttons, door handles, unless you absolutely have to. If you're using the restroom, after you've washed your hands, take that paper towel and use it to open the door with. A lot of places now have trash cans right outside the bathroom doors, and that's a great place to drop it off. Unfortunately, this virus can last for several days on steel or plastic surfaces, and that's something to keep in mind. Soap and water are definitely our friends. I hear people panicking because they can't get hand sanitizer, but as far as I know, soap is still available and we still have lots of water. So very important to be using soap and water, and we'll take a look at why this is so important. You want to do that for about 20 seconds. And the reason for that is it's the friction of you rubbing your fingers and hands together that actually removes bacteria and viruses from the surface of your hands. So this is a really interesting set of photographs that show how when a tracer is placed on hands that lights up under UV light, what happens when you wash your hands. So the first slide shows before hand washing has occurred. And then as we move across, we can see what happens when you just simply rinse and shake your hands out. And there's still an awful lot of the tracer there. 6 seconds with no soap, still a lot of tracer there on the hands. If we have 6 seconds with soap, we start to see material being removed from the hands. 15 seconds with soap, more of the tracer is gone. And when we look at 30 seconds with soap, we can see that although there's still some elements of the tracer there, the hands are much, much cleaner. And this is what we want to try to achieve. So what are some of the societal tactics that we've put in place and what seems to be working? Certainly, every county in America has activated their emergency operation plans, and in Westchester, where I work, we're no different. Even at the federal level, they have put their task force at work, trying to figure out how we can support, how they can support the states and local governments. There have been extended travel restrictions. I mean, we started this project, this whole operation around COVID, dealing with travelers coming into the United States from China and placing those individuals in isolation or quarantine to try to prevent the spread of this infection. Then we started getting travelers from South Korea, Italy, Iran, and again, seeing cases of COVID coming into our country. And so if there's areas where there are large numbers of cases, having people quarantine at home and not traveling is certainly a good way of reducing the number of cases that can occur. Canceling large and medium-sized events, not a time to be having a large party. And many, many events have been canceled for this reason. We don't want people congregating together because that helps spread this infection. In New Rochelle, we did have an area of containment zone that was established. It was a 1 mile perimeter. This containment zone did not keep individuals from traveling outside the zone, but it did limit large events such as religious observances, schools being in session, and trying to reduce the number of people that were congregating together as a way of reducing the spread of infection. We have seen the ramping up of testing and drug development and all kinds of public and private partnerships where it comes from companies now creating ventilators that used to create cars or other things, companies trying to create personal protective equipment who used to manufacture other items. So I think in large ways our country has come together to try to combat this particular viral infection. And if we talk about public health measures, I think the one that most people want to talk to me about recently is the use of personal protective equipment. So in a medical setting, particularly if you're caring for COVID positive patients, you need to protect your medical providers. We can't have our doctors and nurses getting sick. So the use of face shields, masks, gowns, gloves are critically important to prevent those people who are providing care from becoming sick. But they can also be as simple as a surgical mask being put on an individual who is coughing or sneezing to try to prevent spread to other people in something as simple as an office setting. And so if you have people who are sick and they must be at work and they're sneezing, a surgical mask is really is a good thing to do. Laboratory confirmation of cases. We went from only CDC being able to confirm cases to state laboratories being able to confirm to now we have private laboratories doing COVID-19 testing. And the number of days that it's taken has substantially reduced from 5 or more days down to, in some instances, 24 hours. And we hope very shortly that we will have point of care testing that can be done very, very rapidly. And this is very important. I cannot express the importance of risk communication and education. This is a circumstance where we need every single person in America to understand what their risk is and how they individually can protect their health. We need everyone to cooperate, everyone to follow the social distancing and all of the educational parameters that we've set out for how they can keep themselves, their family, their community safe. And if we all work together, we can reduce this infection through those measures. At the health department, we are reaching out to positive COVID positive individuals, trying to determine who they might have given this infection to, who's most at risk, and following up with these people, suggesting that if they become symptomatic, that they isolate themselves and get testing. And that's really important. So in a minute, we're going to talk about isolation and quarantine and when that's indicated, but just the definition around isolation and quarantine is something that most people really don't understand. So moving on. What are our daily activities around public health? Well, as I said, we're trying to manage case reports, informing people that have tested positive of their results, trying to understand who they might have given this viral infection to, helping those individuals who've been exposed know what they need to do. We're working to assess hospitals, labs, other health professionals with either getting people tested or understanding their test results, everything around lab specimens, identifying sources of infection, and as I said before, tracing contacts. Implementing isolation and quarantine. Isolation, these are actually legal terms. Isolation basically means that you're placing someone who is positive for the disease, you're putting them so that they cannot, in circumstances where they cannot spread the disease to others. That can be as simple as being in their home if there's no one who's susceptible in their immediate space. So like being in a bathroom and a bedroom where no one else is other than they are. Versus quarantine, which is simply removing people who have been exposed from the general population. So individuals who have been exposed to either a known COVID positive case or individuals who are suspected of having COVID. And the quarantine period is 14 days. So we would want them to self-quarantine themselves, maybe at their home, hopefully at their home, or it could be someplace else if that home doesn't work, where they would not expose others to this illness should they become positive. And then just try to keep the public and the medical community informed. So this is an example of drive-through testing. In Westchester County, we have drive-through testing at a couple locations. Glen Island, the state has drive-through testing at Glen Island, and also Westchester Medical Center has drive-through testing on their campus. And so what happens is that individuals get an appointment and they drive up with their car. They never get out of their car. They are swabbed in their car. And then after their information is collected, and then they just drive on, and later they're informed of their test results. So very minimal exposure to anyone. It speeds up the process, and it's a very orderly way to get people tested. So who should get tested? Top priority is really those symptomatic who've had close contact with COVID positive cases. Also individuals who are symptomatic who are contacts to suspected COVID. Because of the difficulty sometimes in getting people tested, not everyone who's a suspected case may have been tested. But certainly if people have the symptoms of COVID and maybe they've been around a confirmed case, we would just want to go ahead and try to get individuals that they were exposed to tested if possible. Symptomatic members of an infected community. So certainly if there's a lot of known cases in a geographic area, people who are symptomatic should be tested. People who have traveled to areas where there's a lot of COVID positive cases, either in the United States or outside of the United States, and people who have fever or severe symptoms for which there is no other explanation. They've got a acute respiratory distress syndrome, no reason to have it. We would be very concerned about COVID. So isolation, as we said, this separates infected cases from others. And I think the topic around isolation that's been most important recently is how do people get off of isolation? So we put people in isolation without a determined time as to how long they will be there. And the time is really now been defined as COVID positive people with symptoms, who had symptoms at the beginning of their disease, then we would want them to stay in isolation for 7 days from the onset of their symptoms and 3 days after they have recovered without the use of any medications to reduce their fever, and they have had improvement of their respiratory symptoms. Now, individuals who test positive, who were asymptomatic, who had no symptoms, it would be 7 days from their first positive test and no subsequent illness. So quarantine, as we said, that's for those individuals who are exposed to known cases but are currently well. And for those individuals, we would ask that they isolate themselves for 14 days from the date of exposure, as long as they have no symptoms. And then if they do develop symptoms, they should get tests done. The only difference there is if the person is a healthcare worker, and if they are a healthcare worker, we would ask them to mask for 14 days from the date of their exposure, to wear a surgical mask for 14 days from the date of their exposure. So what about emerging pharmaceutical tactics? We heard a lot about this from Dr. Montecavo, and certainly the development of specific antibody testing is something that has went from taking a long time to we're hopefully going to be having point of care testing, and that hopefully will happen very soon. We're seeing the repurposing of known drugs such as remdesivir and hydroxychloroquine. And so that is something that is, a lot of trials are currently being done on. I doubt we will see an active vaccine for some time to come, but we are seeing the development of plans around collecting plasma from individuals who have recovered from COVID-19 as a possible treatment for individuals with serious illness. So what can we all do? We can all wash our hands. That's an easy thing to do and really does go a long way to preventing this disease. As I said, remaining social distancing, 6 feet from people coughing or with symptoms, avoiding large crowds, staying at home when you're sick, avoiding contact with others who are sick. If people are sick, they really do need to call in advance before they go to a hospital or urgent care so they can be prepared. The use of appropriate personal protective equipment for all healthcare personnel who are treating individuals who are either positive or symptomatic. And let's not forget that we can also donate plasma after illness in hopes that we can be able to use this product to treat those who are ill. Thank you.
Thank you, Dr. Sherlita Amler. We'll next hear from Professor Roger Citron, Professor of Law at Touro College, who's going to teach us about legal and policy issues in the midst of a pandemic. Professor Citron, we look forward to your remarks.
Thank you. I hope everyone can see the PowerPoint and can hear me. And the preceding, Dr. Amler's presentation preceding mine was perfect in the sense that what you heard was the law in action. The law, how do we respond at the local level to the pandemic? I'm going to take us back, sort of take perhaps maybe not a 10,000 foot view, but a longer view, if you will. And let me start by noting that no conflict of interest. And I'll start with what is now a hypothetical question, but seemed quite possible on Saturday, about 2 days ago, over the weekend. You may have seen in the news that President Trump was thinking about ordering a tri-state quarantine, right? New York, New Jersey, and Connecticut. And essentially, it would be an order, a federal order from the president that would lock down those states. Now, immediately, Governor Cuomo, when asked about it, was critical and said that, among other things, he did not believe that such a quarantine would be legal. And so the question is, who is correct? And because I'm a law school professor, the answer is always to a question like this, well, it depends. And the first, it depends on sort of two parts or two pieces. The first has to do with governmental authority generally to respond to a pandemic, an emergency, a crisis. And actually, the government is given great power in these situations. However, we have to also understand or address the question in the context of constitutional law, in the sense that, as we all recall from high school social studies, governmental power in the United States is divided. Significantly, it's divided in two ways. The first is between the federal and state government. That's what we call federalism, the idea of dual sovereigns. And then the second thing to recall is that the notion of separation of powers, that governmental power, using the federal government as an example, is divided across three branches of government: the legislature, Congress, the executive branch, President Trump, and the executive branch agencies, and of course the judiciary. We find those in Articles 1, 2, and 3 of the Constitution. So on what I want to do now is sort of walk us through the relevant legal authority for quarantine in a situation such as this one. And then we'll come back to the question posed, could the president in fact order this quarantine? Now, principal authority, primary authority to quarantine by government and to enact the type of isolation measures that we just heard about, that is found at the state level. And that authority is given to the states pursuant to what is known as the state's police power under the 10th Amendment. The 10th Amendment, part of the Bill of Rights, the idea that power not expressly delegated to the federal government is reserved or ceded to the states. And what the police power does, is it gives the government the authority to regulate activity within its boundaries, within the state, intrastate, to protect public health and safety. One aspect of federalism and the fact that we have 50 state governments is that there will be variations in state laws and actions taken in response to the pandemic. So for example, we know from the way that the virus has affected New York, that New York has taken measures that other states may not yet have taken or adopted. And that's entirely consistent with our structure of government. Justice Brandeis famously said that states are laboratories of democracy, and such variation is permitted in our dual system of government. Nonetheless, to reiterate, the key point here is that the primary authority to quarantine and to isolate exists at the state level. And that's why you see our governors highlighted so prominently in the news. Nonetheless, it must be noted, if I can move to the next slide, there we go, that there is federal authority to quarantine. And this is consistent with other areas of constitutional law in which the federal government has the jurisdiction or the authority to quarantine on an interstate basis, or what I've called a foreign quarantine. And that's the idea that someone coming from another country to the United States, that there is, the federal government has that authority, if the person poses a health risk, to quarantine that person. Same way that the federal government has the authority to prevent travel between states, right? Interstate travel. And the federal government holds that authority, or is given that authority under Article 1 of the Constitution, the Commerce Clause. And examples of this I have on the slide, the CDC, right? The Center for Disease Control, a font of valuable information during this time, right? It is authorized under a federal law, the Public Health Service Act, to do the things that it is doing. Another example, one that predates the pandemic, but one from this century, there was the federal do not board list for air travel. The idea that the airlines are given the authority to stop someone from flying, to not let someone on a plane if that person poses a health risk to the passengers on the plane. And when you go back and look at how that authority has been exercised, at least in the most recently, prior to this moment, we were talking about a passenger with tuberculosis and that person not being allowed to fly because of a health risk that person posed. Now, what have we done so far? We've sort of traced out the idea of federal, of governmental authority, and we see that state has primary authority, federal government has some authority, and of course that federal government authority is divided across the legislature, the executive branch, right, the president's authority to take care that the laws are executed through various agencies. Now we come to the courts, and we've talked about government authority, but of course the exercise of governmental authority here inevitably will brush up against, may be in tension with, may even conflict with individuals' civil liberties. And what you see when you look in the case law, what you find is that it's a classic law school balancing test. That on the one hand, the government is given, as it turns out, in times like these, great deference, right? We balance the government's authority to act to protect public health and safety against individual liberties. And so the general tendency, what you'll find in the case law, is that courts uphold action by the government, by the political branches, when taken to protect public health. The qualification is that the governmental measure must not be arbitrary, oppressive, and unreasonable. And so, you know, when you look for older case, you find a body of cases from really the early 1900s. There's a 1905 Supreme Court case involving mandatory vaccination at the time of a measles outbreak. There's a fairly famous or infamous case from San Francisco in the early 1900s about an outbreak of bubonic plague. In that situation, the court actually said that the way in which the cordon sanitaire, right, the sanitary cordon around the area was being applied in a discriminatory way and required the government to modify that action. So where does this lead us with the question of, and it's purely hypothetical because as we know, President Trump did not proceed to pursue a tri-state quarantine, a federal tri-state quarantine. Instead, he directed a travel advisory, and that measure, less intrusive, less invasive, consistent with measures already being taken by the states. But let's try and answer the hypothetical question. Note that when the president floated the idea, when he brought up the possibility, that what he was talking about was a federal order not authorized by or pursuant to congressional legislation. So, on the one hand, while we recognize that the government is given great deference in these situations, we have to recognize that this would have been a novel exercise of federal authority. There may have been a federalism problem, that is, the states may have objected or resisted and interposed a legal objection that this was intrusive on their authority. In addition, another view is that such a measure, if it came to that, would be one in which it would be infinitely more legally supportable, or substantially more legally supportable, if Congress authorized legislation for such a quarantine. The last thing I want to point out before I go on to the last slide is that there's a paradox, if you will, in such a quarantine measure as a practical matter. And that is, what if it was massively resisted? That is, what if people said, you know, this goes too far, we're going to congregate in public, we're going to resist, you have to arrest us. And that, of course, would contribute to the very problem that such a quarantine measure would be designed to address, right? Because it would put people together, it would put them in proximity. And so that's a dynamic of public health law, the relationship between the public that also has to be considered and taken into account. The last thing I'm going to do very quickly, all of our everyday lives are being greatly affected, and there's government action being taken in response to that. This last slide, puts up a number of items and links about certain developments. And you'll see that there's the stimulus legislation, forbearance regarding mortgage payments if there's financial distress as a result of COVID-19, restrictions on the New York courts being open only for essential business. The last link, a Long Island organization that's aggregating resources to help people through these times. And the advice that I would give would be, you can start at these places, but you have to do more investigating to figure out what is best or appropriate or what is available given your personal situation. Thank you so much.
Dr. Halpern, who's the Chancellor of New York Medical College, is back on, and we welcome him to speak about one of the things he does other than being a pediatric radiation oncologist, which is focused on ethics and the history of medicine.
My topic for today's webinar is the mental angels of our nature, or maybe not, a medical historian's perspective on bigotry and xenophobia. Next. I have no conflicts of interest to disclose for this webinar. The phrase, the better angels of our nature, comes from Abraham Lincoln's first inaugural address. Talking to a nation torn asunder by the Civil War beginning, Lincoln said, next, "We are not enemies, but friends. We must not be enemies. Though passion may have strained, it must not break our bonds of affection. The mystic chords of memory will swell when again touched, as surely they will be, by the better angels of our nature." One would have hoped that in the current pandemic that the better angels of our nature would also have risen to the top, but unfortunately, sometimes they have not. Next, please. We have seen elements of xenophobia during this pandemic. Xenophobia as a word has its roots literally in fear. Phobia comes from the Greek word for fear, and xeno comes from, you guessed it, stranger or foreigner, fear of foreigners. Next, please. The issue of xenophobia in the pandemic was brought to our attention about 10 days ago. This photograph taken over the president's left shoulder shows the text of the president's speech. As you know, my administration phobia in the American people and the American economy from the coronavirus. Now, and the word Chinese is written in. And thus we started to hear some government officials refer to it as the Chinese virus. Next, please. From whence in the history of medicine did the idea come of naming infections after nations or cultures or races come? Well, it is in the Western tradition an ancient practice. For example, next please. We have the 10 plagues of Egypt, the ones affecting humans occurring, next please. In the 6th plague, infesting boils will break out on men and animals throughout the land. And next please, the 10th plague, where every firstborn son will die. There will be a loud wailing throughout Egypt, worse than there's ever been or ever will be again. In more recent history, next please, we have an epidemic which the Europeans blame on the French. Here you see the Christ child seated on the Madonna's lap and gesturing to his left to the pockmarked faces of women, as opposed to the noble warrior on the left side of the image having a crown placed on his head. This is a representation of syphilis and the spread of syphilis, and it was called by some, next slide please, the French disease, being blamed on invading French troops in northern Italy. But the French got a bad rap because almost certainly historians have taught us, next please, syphilis enters Europe, not from the French, but from Spanish plundering of the New World. And so calling it the French disease, something which did not originate with them. But to pay back the Spanish, we blame the Spanish for a flu which wasn't their fault. Next slide, please. Which was the great influenza epidemic of 1918, 1919, causing more than 50 million deaths worldwide, 650,000 deaths in the US at a time when the United States population was 103 million. And as of the time I'm recording this, we have a little over 2,600 deaths in the United States and a US population of 331 million from the coronavirus. Next, please. Naming diseases after someone else is a way of othering them, of somehow placing the blame on someone other than yourself. Next, please. And the most unequivocal example related to Asian Americans before this term, the Chinese virus, was the expression the yellow peril of the late 19th, early 20th century, as illustrated by this political cartoon. Next slide, please. Of Uncle Sam giving the boot to a Chinese immigrant trying to protect California, Oregon, Washington State from Asian immigration. And you see the rising Japanese sun with a yellow coloration off into the Pacific Ocean. And unfortunately nowadays, next slide please, with the COVID-19 outbreak, Asians are facing discrimination and violence amid the outbreak. Next slide please. It would be appropriate, insofar as we are faculty of the Touro College system, that I take note of the particular historical sensitivity of Jews regarding the concept of othering in relation to infectious disease. I will offer you two examples: the Black Death in the 14th century and Nazi references to Jews as either the bearer of infectious agent or being infectious agents themselves. In the next slide, I show you a engraving from Belgium from around the 1340s, showing the mass slaughter of the Jewish community in Belgium as punitions that the Black Death originated from Jews. And in the next slide, you see a Nazi poster in Polish blaming Jews for the spread of typhus. They're like a louse and they're unkempt and they bring infection to us. Next slide, please. A little brief historical tour of naming diseases after countries. The first conclusion we might draw, next slide please, is the story of cut flowers in a vase. Next slide. Trying to understand the best way to respond to an infectious disease outbreak without an understanding of history is the equivalent of thinking you can grow cut flowers. Next, please. Viruses don't have nationalities. Next, please. Xenophobic labeling of diseases may be justly referred to as othering or scapegoating or bigotry, and you would have hoped that in the United States we'd outgrown this form of behavior, that it was more than 100 years old. But clearly some people have not outgrown xenophobic labeling by calling a disease a Chinese virus instead of its proper name, a type of coronavirus. So when some people engage in xenophobia, other people need to denounce it. And I think I just did. Last slide. Thank you for listening, and I hope you're enjoying today's webinar and finding it instructive.
Thank you very much, Dr. Halpern. The question on everybody's mind is, of course, what happens now? You've heard a lot about where we are. I'm not a prophet, but I feel relatively comfortable saying the following. I think, unfortunately, for the next couple of weeks, things will get worse. The isolation methods that have been put in place didn't fully start until a week or two ago. And with the average incubation period of 5.2 days, people are still getting infected. The potentially very exciting treatments that we heard about haven't gotten there yet. But I do believe that if we band together and work together, follow isolation techniques, combat the loneliness, increase testing, test the new drugs, some of which have shown promise, starting in 2 to 4 weeks from now, things will begin to get better. That doesn't mean that I'm confident that things will go back to normal then. They won't. But hopefully at that point, we'll see a bending of the curve and the light at the end of the tunnel. Thanks again, everyone, for listening. And Touro College and New York Medical College will continue to follow the COVID-19 epidemic and try to provide you with the skills and information to get through this together as best we can. Take care. First question is for Dr. Sharita Amler. It seems like quarantining ourselves is intended to slow the spread of COVID-19 virus, and lessen the burden. But after the restrictions are eased, isn't it true that the virus will be just as contagious and that people will get sick anyway?
Well, this is exactly what we talk about when we say flatten the curve. So what usually happens when you have a novel or any infectious disease is you see that all those individuals who have the ability to contract the disease get sick. And so you get this massive peak that occurs where you have large numbers of people getting sick. And the potential problem with that is that all these ill people will overcome our medical system's ability to care for them. So you get your hospitals overrun with ill individuals, and then you can't take care of even the people who are there with the normal illnesses, heart attacks or injuries. And it can result in a lot of people dying unnecessarily. So what we're trying to do by keeping people isolated is to reduce the number of people that get this all at one time, lower the curve, flatten it out a little bit so that our healthcare system can stay intact and potentially reduce the number of people who die. So, you know, eventually when people start going out, we hope by that point in time that the system is less stressed and that we have pharmaceuticals able to treat them, and that it'll be less of an issue. But we're trying to keep the medical community, our hospitals intact, and reduce the number of people who die.
Thank you. Next question is for Dr. Montecalvo. Questions about two potential treatments. One is ACE inhibitors. You mentioned something about the ACE receptor. And the second is the usefulness of steroids to suppress the immune response.
Thank you. Can you hear me okay?
We can.
Great. So regarding ACE inhibitors, this is an open question. What do I do if I'm receiving an ACE inhibitor for the treatment of hypertension? And clearly, we know that the ACE receptor is important in this infection, but we don't know exactly what the risk of being on an ACE inhibitor may pose. And as I had mentioned, there are studies that are going to be looking at this very carefully to follow patients with hypertension who either are on or off ACE inhibitors and have COVID-19 to determine what the risk may be. In the interim, I think it's an issue that really has to be done on a case-by-case basis, that whether it makes sense to switch from an ACE inhibitor depends upon what one's other options are, how complicated it is to switch off of it, and what your exposure is. If you are at home and you are not exposed to anyone, then as Dr. Amler said, the risk of infection is very, very, very low. So it may not make sense to switch a medication that you need under those circumstances. So it really has to be done on a case-by-case basis. Regarding steroids, the WHO came out early on with this epidemic and said that steroids should not be used because it was looked at with the SARS epidemic, and it was felt that steroids were not beneficial for the treatment of viral pneumonia.
Thank you very much.
The question that I've been asked to address is any tips on coping with feelings of loneliness during self-isolation and quarantine? So I think it's fair to say that all of us are experiencing some degree of loneliness and isolation. We need to do that for medical reasons, but that doesn't do away with those feelings. So what can we do about that? So first I want to say I don't believe there are any complete answers. We are isolated, and that is going to engender some feelings of loneliness. There's no way of doing away with it completely. However, what we can perhaps do is mitigate and minimize those feelings. So what can we do? I would share 4 or 5 points. While it's not the same as being there, this is one time where having our various devices, from the phone to iPads and other kinds of things, where we can reach out by phone or by FaceTime or Zoom, whatever it might be. We do have the capacity to reach out to loved ones, to friends, to the important people in our lives. And again, it's not the same thing as being able to give someone a hug or a kiss. It's not the same thing as being in human contact with them. But it is something. It certainly is something, and we should take advantage of our devices to do that. The holidays are approaching, and I think it's an especially important time before the holidays and during the holidays to reach out, to people. I'm going to come back to this in just a second, but let me share a second point, and that is that we could dwell on our isolation and feel only more lonely, and that's exactly what we don't want to do. One of the most important things to do during this time in general is to keep busy, not mindless busy, but busy, and to keep to as much of a routine. We're all out of routine, but to the degree that we can keep to a routine, the more routine, the better. So during the day, we should be doing our work, if we're fortunate enough to have work. And certainly many of us have children who are home from school, children or grandchildren, and obviously that's a time to be spending with them and working with them and so on. And so that's where I think our focus has to be, sticking to routine, sticking to the important facets of our life, family, friends, work, those things that bring meaning to our lives. And then again, reaching out to people, whether it's for collegial work-related reasons, and certainly for in terms of family and friendship. So that would be the second thing I would say. The third thing, and this is very important, is exercise. It's so easy when we're kind of stuck at home to be out of routine and not to do exercise. Well, if you regularly do exercise, you should continue to do exercise. The kind of quarantine and isolation that we're experiencing does not prevent us from doing exercise. Take that walk, take a run, have a conversation from a distance as you're taking that walk. There's a push-up challenge that's going on online these days. Do sit-ups, whatever it might be. You can't go to the gym, but we're in spring and the weather hopefully is going to start to get nicer. Get outside if you can, do exercise. Exercise releases endorphins, and those literally lift up our mood. And by the way, exercise is best done in the morning. There are a lot of studies that show that the greatest benefit that we get is from exercise. So keep in mind that since things are different, many of us are at home working remotely. We are not commuting. That saves some time. That gives us back some time. That's perhaps one of the benefits of a less than ideal situation that we're in now. So exercise in the morning, ideally, doesn't have to be the morning, but that is the best time to do that. And then sleep. On the other end, it's sort of like start with exercise in the morning, and then there's sleep at night. Sleep provides us with many benefits. You might be saying to yourself, we asked you about feelings of loneliness and isolation. What does sleep have to do with that? Well, sleep is an opportunity for us to process what we're feeling on a more unconscious level. It's an opportunity for us to re-energize and engage for the next day. Good sleep helps us to see things when we're awake from a more accurate perspective and a better perspective. So please make sure to get enough sleep. Maybe the most important thing that I can share with you, and this is the hardest in some ways, is that I would suggest that every day that you take some time, perhaps before your bedtime routine, right? Doesn't have to be then, but that's a good time, because that can help to also prepare you for a better night's sleep. But I would close my eyes and I would picture a time when this is over, and picture how you will reconnect with the people you love and want to be connected to. So whom will you reconnect with? How will you reconnect with them? Maybe even where will you reconnect with them? It's okay, to fantasize a little bit here, whether it's fantasy, or, fiction, fantasy, or reality, when this is over, and it will be over, Am I going to get together with my friend and are we going to take a trip, across country? Are we going to take that trip to England that we've always wanted to take? Are we going to go up to the mountains? Or are we simply going to meet in Starbucks or in a coffee house and have a cup of coffee and have that human proximity that means so much to us? So again, close your eyes. Picture, what will you do that when you can't, what will you do when you're able to do what we're not able to do now? It seems to me the most important thing that we're missing, that we're not able to do, is to be in human, interpersonal, personal contact with one another. It could be something else that you can envision in your mind's eye that you're not able to do now, that you will be able to do then. So again, whether it's envisioning something, not of a human nature, or picturing a place, that island beach that you want to go to, and most important of all, picturing the people that you want to connect with, a loved one, a family member who maybe you won't be able to have the holidays with now, but who you're going to get together with for the next holiday, for the next, when this is over. So again, it doesn't do away with loneliness and isolation, but these are, I believe, some tips that can help you significantly minimize that. So again, reach out to the ones that you love. I'll date myself a little bit, but there was a time where there was, some of you may recall ET, phone home. So phone home or FaceTime home. Keep busy, keep to a routine as much as possible. Make exercise part of that routine, ideally in the morning. Make sure that you don't worry about getting sleep, but get a good night's sleep. Be in a sleep routine and make sure that you bring no devices with you to your bedroom, and get a good night's sleep. And then again, periodically, it could be every night before you get ready for bed, whatever time works for you well, close your eyes, go into your mind, be in the moment to imagine a different moment, a time when this will be over, when you'll be able to reconnect and get to things that you're not able to do now. I hope that this is helpful to you, and I hope for you a calm and serene and feelings with less feelings of loneliness and isolation. Thank you.
This is Dr. Robert Amler again with a question number 9 from a viewer who writes, I was wondering if you could speak to the role and prevalence of asymptomatic carriers based on the research that has come out so far. As a younger person with no risk factors, I'm concerned that I could get COVID-19 and not know it. Do we know how long people can shed or carry the virus who don't have symptoms? This is a great question because it speaks to the very problem in containing this outbreak right now. As a young person, you are less likely to have symptoms, less likely to have severe symptoms, less likely to die, which is great, but you may not have enough symptoms to know that you're carrying the virus. And your question about asymptomatic carriers, that's people who could be infected and not have any symptoms at all, is a real question. It is not known yet how many such people there are or how many people could be carrying the virus and not know it. This means we all have to be careful about spending time with others, about touching things with our hands when we haven't washed them, and particularly worrying about friends, family, loved ones who are older or have underlying conditions who could be at great risk if you give them the virus. So what can you do? You can just be extra careful at not passing the virus to others. Keep a distance of 6 feet, wash your hands frequently. When you touch surfaces, wash them off, wash your hands, and be extra careful for the duration of the outbreak. And thank you for your question. This is Dr. Robert Amler again, and I'm responding to question number 10. A viewer writes, how long does the virus last on surfaces such as glass, plastic, metal, What should I be doing to disinfect surfaces? Well, you're exactly right. Some studies have shown that living virus can be recovered from these smooth surfaces like metal and plastic, probably glass, as much as 2 or 3 days after the virus was deposited on the surface. So you need to be careful. And again, it's a great indication for regular hand washing because you may pick up living virus from those surfaces just from an innocent touch of the hand. Then you touch your face and you could inoculate yourself with the virus. The best way to cleanse those surfaces is with soap and water or with a disinfectant like a hand sanitizer, ethanol, and even bleach, which when it's placed on the surface should not be wiped off, but just allowed to dry. Thank you for your question. Question number 7 is for Dr. Shirlita Amler. Is it safe to take a walk outside?
I think it's not only safe, I think it's a great idea. It's very important for people to keep up their emotional well-being as well as their physical well-being. And being outdoors, as long as you're keeping social distancing, you're not closer than 6 feet or in large groups, I think it's an excellent and healthy idea.
Question number 11 is also for Dr. Shirlita Amler. How long after COVID-19 infection does a person remain infectious?
Well, we don't know the exact date, but our current protocol says that a person who is under isolation, so they've tested positive for COVID-19, can be removed from isolation once they have been more than 7 days from the onset of their symptoms, and they've had 3 days where they have had no fever without the use of Tylenol or other antipyretic medications, and also that their respiratory symptoms are improving.
Question number 12 is also for Dr. Shirlita Amler. Is it possible to get the virus a second time?
Unfortunately, no one knows the answer, and only time will tell.
This question is for Dr. Montecalvo. We are a small primary care office with 2 physicians who decided to close as of March 20th. We initially stated that we would close for 2 weeks. I am thinking that we should close longer. We are providing telemedicine visits, although it is challenging to our older patients who are not computer savvy, don't even have an email address. When is a good time to reopen? Should we see patients except upper respiratory infection patients and change those visits to telemedicine visits with the understanding that we cannot listen to lungs, check a temperature, or check a pulse oximeter, or should we remain closed? This is Dr. Montecalvo responding to this question. So this is a complicated situation. Now that you're 2 weeks after having closed, the question is really what to do for the long haul. And it appears as though it's going to be a long haul. We at least have several weeks ahead of us, which appear that they will be very similar to as things are now. I think that it's terrific that you're offering telemedicine, but obviously there are patients who are not going to be able to be served by telemedicine. And for those patients, I think telephone calls are very appropriate in trying to document over the phone and understand what's happening. But there may be a small group of patients who you really can't manage either by telemedicine or telephone. And for those patients who you are concerned about that truly, it would be beneficial for them to be seen, I would encourage physicians to provide limited hours for those patients, being sure to have personal protective equipment and screening the patients in advance for any symptoms consistent with COVID, so that if they had anything at all suggestive, the person could be appropriately given a surgical face mask before entering to try to maximize protection for the healthcare worker and for anyone in the surrounding area. It is important during this time that we don't have unintended consequences of the measures that we've put into place, of the social distancing and only going out for essential services. And there may be elderly people whose medical conditions really require them to see a physician. And I think we do need to find ways to see them, but many, many patients can be managed over the phone and through telemedicine. And so the ones who need to be seen can really be reduced down to a select few. And that is how I would approach it. Thank you. Another question that we have directed to Dr. Montecalvo is, can you please talk about what this pandemic means for pregnant women and newborns? Pregnancy is obviously a time of being even more careful than one normally is about one's health. There are data from China that in a small number that indicate that there was not intrauterine transmission of COVID, which is reassuring, but the number of patients that have published information the number is small. I think that the pregnant woman needs to be, at least as careful as everyone else, if not even more so, and would do what would normally be done to care for a newborn. If the mother were to develop symptoms consistent with COVID, it would be important to establish that diagnosis. You may not be able to separate from a newborn. One might be breastfeeding. You may need to consider use of a surgical face mask with a newborn if one were symptomatic. And all of this would be very important to stay in close touch with the obstetrician and the pediatrician involved in the person's care. Another question for Dr. Montecalvo is the following. 3 people have asked variations of this question. My children and my grandchildren are in New York City. My husband and I are in our 70s and have been staying at a vacation home we own hundreds of miles from New York. Things are pretty quiet here, not like what I see in the news about New York. My daughter and my son-in-law want to pack up our grandchild and come stay with us for the duration of this event. None of them are sick, and they have been working from home for the last 10 days. I'd love to see my grandchild, but I don't want to take a foolish risk. What do you advise? So New York City is obviously an epicenter of COVID-19. Anyone who is leaving New York City to go to another location at this point is to self-quarantine. So I would not say that they can't come. I just think that as long as they are well, they could go to their destination to be with, I guess it would be with their parents, bringing the grandchild with them. But the house would need to be set up in a way that would allow the parents and child to self-quarantine for the 14 days to be sure that they are not incubating COVID-19 and transmitting it shortly after their arrival. So I think as long as one could set up a situation that would allow for a self-quarantine upon arrival, with one using their own bathroom and the other details involved in self-quarantine in the household, I think that it's very reasonable. And once those 14 days are completed, you have outrun the incubation period. And if one has not developed symptoms, your risk at that point is really your risk from your new location, which is the same risk that the grandparents have at that point. So that's how I would approach it.
I'm Roger Citron, and I've been asked about how to stay up to date on the medical and public policy implications of the pandemic. So I have three thoughts. First, the Center for Disease Control and Prevention, its website is outstanding. It's a must to keep abreast of what is going on medically with the pandemic, and some of what is on its website gets to public policy implications. So I highly recommend that website. Second, I'm going to share screen and go to my last slide from the presentation. I went through this quickly, and the reason why I'm sharing it again is because there are so many things happening. There are so many sources for information that I think you have to be a thoughtful and in some ways proactive consumer and look for the information that's most relevant to you. The first bullet point was links to a New York Times summary of the federal stimulus legislation that included payments to individuals, expanded unemployment coverage, benefits for unemployment, and made changes with respect to student loan repayment. I have to tell you, if you go to the article, you will see that in fact they had to correct it. There's a correction at the end of the article, and I say that only so that you have a sense of how much is going on and how important it is to be thoughtful, thorough, and proactive in trying to find out what may relate to your situation as we go through the pandemic. The other three links that you see, this is to, and these are different sources of information, is to a state government website, the Department of Financial Services, that has information about forbearance for mortgage payments. There's a comparable rule or forbearance policy in place with respect to evictions. To find out more, you can go to the New York State Department of Financial Services. It's a government website. Last two websites linked here on the bullet points. One is to the New York courts website, emphasizing that the courts are open for essential business. What does that mean? You have to go to the website and find out. The last website is this Long Island voluntary organizations active in disaster. And it's a real grab bag in a good way. It's aggregating information about food sources, housing issues, and other actions being taken in response to COVID-19. So the last point in conclusion is that there are many sources of information And it's up to you really to keep track of and find out about what's going on. But all of these places are starting points for issues that may affect you. Thank you.